Good afternoon, everybody. Welcome to our Texas Collaborative for Healthy Mothers and Babies Newborn Admission Temperature Project launch webinar. I'm Patrick Ramsey. I'm the Chief Medical Officer for the Tchmb, and we're very excited to have you all with us today. We have over 278 individuals registered for the meeting today, representing 135 hospitals from around the great state of Texas. So we're really excited about this Newborn Admission Temperature Project. As you are aware, the Texas Collaborative for Healthy Mothers and Babies is the state perinatal quality collaborative for the state of Texas. And about a year ago, we launched a major initiative to merge the collaborative's efforts with the efforts of the PCR Alliance and the RAC PCR. And we're very pleased to announce that that's been very successful. And this project's one of the premier initiatives from that collaborative effort. So really excited to see this project go forward. Just a couple housekeeping things today, and we'll go through the outline. Please keep yourself on mute during the webinar. We'll have an opportunity to chat in the chat box as well as unmute later, I believe. So please keep yourself muted during the main presentation today. The session is being recorded, and there will be a recording available on the website along with the slides from today's presentation as well. Just so this will be available for other people who are part of your teams that are not here today to go back and listen in. And I just saw the comment in the chat box. Please put your name and institution and who you're representing in the chat box. I think it's great for us all to get to know each other as part of this launch for the project. All right, so the outline for today, first, Divya Patel, who's the Director for Research for the Collaborative, will give a little high-level overview of what Tchmb is, as a Tchmb 101 type of presentation, and what we're all about and what our goals and objectives are. And then we'll hand it over to Dr. Wyzoli and Dr. Lloyd to talk about the RAC PCR Alliance and integration that I mentioned, which has been really, really exciting for all of us. And then Malia and Amanda will take over to talk specifically about the Newborn Admission Temperature Project. And then we'll wrap up with question and answers. And again, if you have questions and answers as we go forward, we do have people monitoring the chat box, and we'll be glad to answer those questions as we go forward. If we do not get to your question and get it answered, we will certainly respond to your question and get back to you with those answers. So with that, welcome. I would like to hand it off to Dr. Patel to give a little overview of what the collaborative is all about.
Thanks, Dr. Ramsey, and thanks to everyone who's joining us today. I was quickly looking in the participant list. It looks like we're already over 200, so I'm really excited to be here and share on this exciting project with all of you. So my portion is just going to be to give you a quick overview of Tchmb, which is, like Dr. Ramsey said, our state perinatal quality collaborative. And what you're seeing here is a map of where all of the PQCs are in the country. So you'll see that most states in the country have a perinatal quality collaborative, and Tchmb is our state perinatal quality collaborative. So our mission as a PQC is to advance the healthcare quality and patient safety for all Texas mothers and babies through the collaboration of health and community stakeholders. So our collaborative is made up of many members, and our executive committee is made up of a broad range of experts, and it's very multidisciplinary. We have representation from obstetrics, maternal fetal medicine, pediatrics, neonatology, nursing, community health. We also have on our executive committee representation from many organizations around the state and regionally that represent maternal and infant child health. So we have partners at Department of State Health Services, many other state agencies. We are represented by March of Dimes and Texas Health Hospital Association, Texas Medical Association, ACOG, A1, Texas Pediatric Society, and many others. We're very proud to have partnered with the PCR, the perinatal care regions, as part of our new integration with the RAC PCRs. We're really excited that this is helping us move the projects forward throughout the state. So to share just a little bit more about Tchmb. So we are, again, the State Perinatal Quality Collaborative. We work in conjunction with many key stakeholders. So like I mentioned before, Department of State Health Services is one of our key partners. We also work very closely with many other stakeholders, including the RAC PCR Alliance, as I mentioned, Texas AIM, which is the Alliance for Innovation on Maternal Health, and then other organizations and initiatives such as the Maternal Morbidity and Mortality Review Committee, the National Network of Perinatal Quality Collaboratives, and patient and advocacy groups. The way we're set up is that we have an executive committee, and we have 4 different committees that we work on various initiatives and projects, all with a quality improvement focus. We have obstetrics, neonatal, community health, and our newest committee, which is the data committee. With respect to our leadership of TCHMB, our chair is Dr. Catherine Epps, and our vice chair is Dr. Rashmin Savani, and we have many other distinguished members representing on our executive committee leadership. This is just to give you a little bit of an overview of some of the names. If you want to put names to the organizations, you can kind of see that we have representatives on our executive committee from the PCR Alliance, Dr. Lloyd, from the Regional Advisory Committee, Eric Epley, Perinatal Advisory Council, Texas Hospital Association. I've listed many, but we are a very multidisciplinary team. In terms of our own staff here at TCHMB, I'm the research director, as Dr. Ramsey mentioned. We also have Dr. Ramsey as our medical director, Sheena Abraham as our program director. And then we have a team that has a lot of diverse expertise, including our quality improvement nurse, Amanda Wagner. You will have probably come into contact with Dr. Maliha Salahuddin, who's our epidemiology lead. We have other representatives that lead some of our community health data and other initiatives. These are some photos of our team, just again, to put faces to names. In case you have questions and want to learn more about some of the initiatives, we do have leads on all of the committees. This project in particular is being run through our neonatal committee. So as I mentioned, Maliha Salahuddin is the contact for this project. All right. So we have many goals as part of our collaborative, and you can see them here. Broadly speaking, we are aiming to reduce preterm birth and infant mortality, reduce disparities in the health outcomes for mothers and babies, reduce maternal mortality and severe maternal morbidity, improve the health outcomes of mothers and babies, increase involvement of fathers and families, and improve women's health throughout the life cycle. And our core strategies are very much data-driven. They involve collaboration, quality improvement, and education, communication, and outreach. If you'd like to learn more about TCHMB, we have many venues to get you connected. We do have a quarterly newsletter. We have a website that's very easy to find. It's just tchmb.org. You probably have seen promotional emails and ads about our summit and other webinars. And if you're not connected, please put a comment in the chat. We'd love to get your email contact and add you to all of our distribution lists. We also have Twitter and Facebook. So we are on social media as well. All right, with that, I'm going to hand it over to Dr. David Weisoli and Dr. John Lloyd to share a little bit more about the TCHMB and RAC PCR integration.
Thank you, Divya. So again, I want to just welcome everyone and thank you all for taking the time to participate. Now we're up to 240 plus participants, so that's really spectacular. So my name is David Weisoli, and I'm joined also by Dr. John Lloyd from Austin. Just to clarify with people to understand, the RAC PCR Alliance, of which I'm the chair and Dr. Lloyd is the chair-elect, is the Regional Advisory Council Perinatal Care Region Alliance. The concept of perinatal care regions, as you know, was created by the level of care designation process. and the Perinatal Advisory Council, and there are 22 perinatal care regions, which are under the auspices of the RACs, the Regional Advisory Councils. The RAC PCR Alliance is an organization that came together in order to facilitate collaboration and communication between the 22 RACs, their executive directors, and their perinatal chairs. So that's essentially what makes up the RAC PCR Alliance. The perinatal chairs, in some cases, it's a single chair. Some of our regions, it is multiple chairs, and maybe an OB as well as a neonatal chair. And in all of our 22 RACs, there are executive directors or CEOs of the RACs. They are all involved in this alliance. And in fact, our next meeting is this upcoming Friday. We meet quarterly. What is really exciting, as Dr. Ramsey and Divya really began the discussion with, is that for the first time ever, we have all of these organizations in Texas working together to do quality improvement, to improve care for mothers and babies, or to reduce disparities, et cetera. The RAC PCR Alliance members have taken leadership roles within the executive committee of TCHMB, as well as making up the OB and the neonatal committees. There are 22 representatives, one from each of the individual RACs or perinatal care regions, to each of the neonatal committee as well as the OB committee within TCHMB. And this is actually the first project. The Neonatal Admission Temperature Project is the first project of which we will be collaborating and working that axis of the TCHMB in collaboration with the RAC PCR Alliance and with the effectors being the RACs and the perinatal care regions, which all of you are members of and all of your hospitals are stakeholders within. So our goal with this collaboration is to establish a statewide collaborative, in this case around the Newborn Admission Temperature Project, and going forward for other projects that come out of the OB committee and the neonatal committee to follow this same type of pattern. So the Alliance will serve as a liaison that really connects TCHMB with every single hospital stakeholder across the state through your RACs. So next slide, please. And so this is kind of just a general graphic of the crosstalk, and Dr. Lloyd can jump in here at any point if you'd like. The TCHMB and the RAC perinatal committees are working together for successfully implementing the project. Many of you have heard from your neonatal committee representative from your RAC. Many of you have spoken with maybe your RAC executive directors or others regarding this project with the attempt to help to promote enrollment and collaboration and cooperation. The more that we do large projects together and that we can coordinate them and not work in silos, the better chance we have, an opportunity we have to improve care across the entire state. And ultimately, therefore, to do things which will gain further support for ways to make improving care perhaps easier on the technology front and other aspects. So we do serve the RAC PCR Alliance as an information conduit between the TCHMB and the specific RAC perinatal committees. We help with active recruitment of hospitals. At the local level, we have people from the neonatal committee, in the case of this project, who are available to give technical assistance at the local level. If you have questions, et cetera, if they don't know the answer, they will be able to rapidly get you to the right people who can give you answers regarding right now what data is going to be collected, the data use agreements, enrollment forms, et cetera. And really, we're going to also help to kind of remind and nicely prompt hospitals to submit the data regularly once they have been enrolled within the project. Dr. Lloyd, did you have anything else that you wanted to add before we go on to our next slide?
Well, I think, David, you summed it up very nicely. I would just emphasize that the goal of this collaboration is to extend the reach of the projects. And I want to say thank you to everybody who's on this call. This is, even if we enroll nobody else from today, which we're hoping to get every hospital in the state enrolled, it's already far and away the largest newborn project that the state has undertaken. And so thank you. That's because of all your involvement and your commitment to collaborate together with us and the TCHMB, which is really a group of people trying to work together to improve the care of mothers and babies. If I can be of any help for anybody, if David can, our goal is to help this project be as successful as possible and move forward together to make the care of babies and mothers better in the state. So thank you so much.
Thank you all.
Thank you, Dr. Wisely and Dr. Lloyd. So my name is Malia Salatin. I'm an assistant professor with the University of Texas Health Science Center at Tyler, and I'm based here at UT System Population Health. And many of you have already heard from me multiple times. So now I'm going to talk a bit more about the newborn admission temperature project. Next slide, please. So our project is led by your project work group members. The work group is led by Dr. Rashmin Savani, who is with UT Southwestern. Our esteemed project work group members include Dr. David Wisely from Memorial Hermann, who is also our neonatal co-chair, as well as the RAC chair, RAC PCR Alliance chair, I should correct that. Dr. Jonathan Netrolo from Cook Children's, Dr. John Lloyd from UT Austin Dell Medical School, again, the chair-elect for RAC PCR Alliance. Dr. Charlotte Aguilera and Dr. Nancy Hurst from Texas Children's Hospital, Dr. Phyllis Wen from UT Southwestern. And from our TCHMB side on this project, we have a number of members who are working on it, including myself, Dr. Divya Patel, Dr. Amanda Wagner, Mr. John Gibson, Ms. Nagla Illyrian, and Ms. Sheena Abraham. Next slide. The Newborn Admission Temperature Project is essentially just a quality improvement initiative that is hosted by Tchmb in partnership with the RAC perinatal committees. Our goal is to increase the proportion of newborn infants with admission temperatures within the normal limits through implementation of best practices. Next slide, please. We all know it is important to track newborn admission temperature. We want to prevent hypothermia-related morbidity and mortality. We also want to prevent any adverse outcomes related to hyperthermia. We also want to reduce variation in neonatal thermal care. And one unique aspect of this project is we also want to look into the racial ethnic disparity that is associated with it so that we are better able to track where the disparity is happening and then act on it to reduce those disparities. Next slide, please. This project has already been conducted at some form by the North Central Texas Trauma Regional Advisory Council, and they have found positive outcomes for all of their newborns, including term infants, where they have seen a reduction in hypothermia among newborns. And our goal is now to expand this project statewide. Next slide. So what are the benefits to the hospital stakeholders? We have a chance now to improve the newborn care of every single newborn birth in the state of Texas by working together. The hospitals are going to participate in a statewide quality improvement initiative, and this project will provide you with some metrics that will help with your QAPI programs as well as to support your levels of care designation. Next slide. So our Project SMART objectives that are specific, measurable, achievable, realistic, and timely. We have both our objectives and all our measures broken down by NICU versus mother, baby, newborn nursery. So our first goal is within 18 months of beginning of the project, we will see a 50% increase in the proportion of infants with normothermia upon admission among infants that are admitted to NICU. And the same applies for the babies who are admitted to mother, baby, and newborn nursery. But here the temperature measurement is going to be between 20 to 60 minutes after birth. Next slide. So this is our project timeline. As you can see, we started off in November with recruitment, and over the past 4 months, we have recruited 50% of the birthing hospitals all over the state. Right now, we are over here in this yellow arrow where that is at. So hospitals would start tracking the baseline data, and they would report the data to us for the first time in July. The data reporting is going to be in a quarterly frequency, and it's going to be at the hospital level. And we are not asking for any PHI or any patient level information. This is going to be all aggregate hospital level data. We also want to emphasize here that we are not closing off enrollment. We would be working with the hospitals that have not enrolled yet or that are in progress. We will be working with you to ensure that to help you with completely enrolling into the project. Next slide. So as many of you already know, the enrollment involves three things. One is completion of that enrollment form. The second part is the data use agreement, which is the one that actually takes the most of the time because it needs to be reviewed and approved by the legal. And the third part is the needs assessment survey, which is a very short survey that asks for a few hospital characteristics questions and some data related questions. Next slide. So again, this changes by day, I would say. So this is already outdated. So right now we have 112 hospitals that have completely enrolled. So we have executed DUAs with all of them. We are working with another 27% of hospitals to get them enrolled. And then we'll be reaching out to the hospitals that have not enrolled yet to help you with the process of enrollment. Next slide. So this is the enrollment map, and I'm really proud to show this. This is all of your doing. This is because of your commitment to improve the newborn thermal care. This is because of because of your contribution. This is what we are seeing. All the green dots are hospitals that have already enrolled, and you can see that it's spread all over the state. And the yellow dots are the hospitals that are in the process of enrollment. And we are going to work closely with you to get you over to the complete enrollment side. Next slide. So like Dr. Wisely had mentioned, this is the first statewide largest neonatal quality improvement initiative. Based on the hospitals that have already enrolled, we are going to impact 50% of total births. And once we get those hospitals that are in progress, once we get them into complete enrollment, we'd be impacting another 25%. So we have the scope of impacting 75% of total births in the state of Texas. But our goal, of course, is to impact all 100%. Next slide. So here, some of the major project activities that's going to come. Of course, the first part is the formal commitment to participate. I've already gone over that. The second that is coming is the baseline, is the data submission. We're going to collect quarterly data, hospital level aggregate data, and the data submission is going to be through REDCap. And after the webinar, we are going to reach out to each of the individual hospitals that have completely enrolled to set up your REDCap account and to give your individual hospital ID. At the same time, we also request hospitals that have not enrolled yet or that are in progress to start tracking your data, because that way we would have a uniform method of data collection and data comparison. And once your hospitals are enrolled, you can just go back and retrospectively report the data to us. The hospitals would also be, we also encourage your hospitals to participate in collaborative calls with other hospitals in your region to talk about, to discuss specifics about the project, what has been working well, what has not been working well, to come up with solutions of what can be done better. And you can do those during your monthly or quarterly RAC Perinatal Committee meetings. We are going to introduce an intervention that is going to be about 6 months into the project, and that is going to be informed by baseline data. We do not want to, the intervention is going to be informed by your baseline data, but we do not want to speak too much about the intervention because we do not want to drift the outcomes. But we do want to mention that the intervention is not going to be labor intensive, and it is going to be something that you can tailor towards your settings. So this is the first, our hope and expectation is that this is the first of the webinar that we are going to kick off the project, but we want to do a subsequent of webinars where we would invite the hospitals to come and present on what you have achieved and what has been going on in your region. Of course, we would also encourage hospitals to share tools to develop, if there are tools and materials that you all are developing specific to data, how to track the data, because we are going to track data for every single birth. We know that there are hospitals, very large hospitals, for example, Women's Hospital of Texas, where they were able to automate their process with their Cerner system. There are hospitals with CPN who have automated their process, as well as Epic. So if there are things that hospitals can share, we would be very happy to connect you to those hospitals so that you can learn more from them about how to automate the data collection process or anything else in relation to this project. And then the final part is the hospitals now have to have the that we'd hope that the hospitals would serve as a mentor to educate and support other hospitals in your region. Now I'm going to hand it over to Dr. Amanda Wagner to talk specifics about the data portion. Thank you.
Thank you. So we know that the data portion is of great concern to many of you, and so we wanted to give you a lot more detail on what that's going to look like for this project. For our NICU partners joining us today, it likely will not involve a change in your process. It will be just your first temperature upon admission to NICU. However, for our mom baby nurses, of which I am part of your ranks, it will be 20 to 60 minutes after birth instead of immediately after birth. Next slide, please. So the measures will be, and we have them listed here between NICU birth weight less than 1,500 grams, and then the newborn nursery. So first, it'll just be the total number of admissions by each department, and then the total number of admissions with hypothermia, total number of infants that were cooled for possible hypoxic ischemic encephalopathy at the time of admission, and then the total number of infants with hyperthermia at the time of admission. We will be looking at breaking all of these measures down by race and ethnicity, and the categories that we've selected are Hispanic, non-Hispanic, white or Caucasian, non-Hispanic, Black or African American, American Indian or Alaskan Native, Asian, Native Hawaiian or Pacific Islander, or other, which might include multiracial, and then unknown or declined to answer. Next slide, please. So our baseline collection period, as Emily had just explained, will be the next 2 quarters. So starting next week, April 1st through the end of September will be baseline. I'm sorry, through the end of December will be baseline, and then we'll be collecting it on a quarterly basis. So for the second quarter, for example, from April to June, you'll collect, and then you have until the end of the next month, July 31st, to submit for that quarter. Then we will have data submission throughout the course of the project. That is, again, same setup, collected quarterly with 1 month time to submit for the previous quarter. And then we'll move into our sustainability phase, which will be starting in 2023 and moving forward from there. Next slide, please. Data collection will be done through a system called REDCap, and every single user will have their own individual user login. Typically, each hospital has just one person who's going into the system and submitting data for their hospital. Every once in a while, we will have a hospital that wants to have 2 people that have access to the system to enter the data for their hospital. If that is the case, each user will have their own individual login, but the hospital will have one hospital ID. Other hospitals will not be able to see your identified data, only you will have access to that. And then REDCap will generate reports that will compare your hospital to the state. It will compare your hospital to your PCR, and there are a couple of PCRs that have so few hospitals that we will be combining them with other PCRs that are also of smaller numbers, so that it's not obvious, for instance, that, well, that's the other hospital in our PCR, for example. So we will combine some of those smaller PCRs to have a greater number there, so it's not completely indicative whose data is whose. And then additionally, it will also have data compared to other hospitals of similar status, for instance, other rural hospitals or other hospitals of your similar delivery volume, things like that. And we will be sending a lot more instructions on how to access this. Every single person will get an email with their login information and instructions on how to get into the system and get set up. Next slide, please. So once we start the data collection, as I said, it will go into the data REDCap portal, and we will have those reports that are generated. No other hospital will be able to see your data. However, we will be sending hospital-specific data to the RAC, to your own individual RAC. Other RACs won't be able to see your hospital, but your RAC leaders will be able to see your hospital's performance. And then you'll also get a report on your own hospital performance. Next slide, please. So this is just an example of what some of the reporting might look like. It'll have your hospital compared to the state average, compared to other hospitals in the state, compared to other hospitals in your RAC. Again, none of it will be identified by hospital. You'll only know which bar is your hospital's. Next slide, please. So I also wanted to touch a little bit on the quality improvement assistance that we offer. First of all, we offer general QI infrastructure and support, and that is through me. I am available to help build your QABI programs or provide some training on quality improvement if your staff is not really familiar with using some of the tools and strategies. Prior to COVID, I would do this in person and come out and help. Right now it's done through Zoom, but hopefully soon we'll be able to resume to normal operations. We also provide project-specific training and technical assistance. So throughout the course of a project, we may offer a couple of webinars. We may create certain tools or other forms of support that are specific to a particular project and provide training on how to use them. We also can help with evaluating your processes to see where there are areas where you could improve, as well as conducting tests of change. And then lastly, we have a lot of support with strategies and methods for data collection, where you can find data, how you can automate some of it. Some of this is through working with other hospitals who have a similar EHR, who have been able to create reporting that we then help other hospitals throughout the state that have that EHR. Some of it is us coming up with things on our own, but those are the types of assistance that we can support you with throughout the course of a project. Next slide, please. So lastly, I just wanted to kind of recap. Malia has already touched on several of these things, but I wanted to bring it all together. So the next steps are you'll receive your own REDCap account with your unique hospital ID. And then next week, April 1st, we start data collection. That does not, that's for the first quarter, needs to be submitted July 31st. And then that will be ongoing every quarter. And then that baseline data, as Malia has said, will help inform the intervention that will be introduced later on in the project, about 6 months into it. We do have an intervention that North Central Texas RAC had used in their project, because we are adding racial disparities and looking at all of these measures broken down by race and ethnicity. We are hoping to see if there are any opportunities to enhance the intervention to specifically address those disparities. So we don't want to give too much information just yet, but there will be plenty of training and information coming at the right time. And then next slide, please. Lastly, we just want to thank all of our stakeholders and partners in this project and the work that Tchmb does in general. Starting, of course, with all of you. We really thank you for joining us in this endeavor and participating on this call today. We could not do this work without your hard effort on the ground. And so that is, you're our heroes. We also want to thank our project work group members on this particular project. They have been instrumental in leading this effort, as well as the neonatal committee members who have really worked very hard to reach out to the hospitals within their PCRs to really enhance and improve enrollment especially over the last month or two. They've really helped get the enrollment numbers up. Additionally, the RAC PCR Alliance has been very helpful. They've welcomed our Tchmb staff into many of their meetings to present and answer questions and tell you about who we are, and that's been, I think, really helpful. Our Tchmb communications team is always making sure everything that we have going on is promoted. And our funder, the Department of State Health Services, are always big supporters of ours, and we're very grateful for their funding and their support and everything that we do. And then lastly, all of the partner organizations that Dr. Patel went through earlier when she was talking about our structure, they've all helped promote this project throughout their own individual organizations as well. And so it's been a team effort, and it's been great to see all of these entities come together and really work to improve the lives and the health of our neonatal people in Texas. So with that, next slide, we want to open it up to, oh, I'm sorry, I skipped a slide. Forgot that I was supposed to tell you all about our next summit. If you want to hop back up to that, Divya. We do have a summit every year. Our next one has been set for February 16th through 18th. So please save the date on your calendars for our next summit. It's always a great time, very motivating, very encouraging. Everyone always leaves it very, very invigorated and ready to do good work. So please save the date for that and you'll be receiving more information. Okay, now if we move forward, I wanted to open it up to if there are any questions for any of the people that have spoken today, or about Tchmb as an organization, or about this newborn admission temperature project. We wanted to open the floor up now for that.
Amanda, I think there are a couple of questions in that were put into the chat, not the question and answer, that probably could be answered for everyone.
All right, I see one here. Is there a data collection tool available to aid in chart review? We have not developed one as of yet. There will be one that we will be developing throughout the course of the early months here. We also have from North Central Texas RAC, there are some hospitals who have figured out how to automate this collection within their EHR. And so we hope to have some resources we can share from them.
I also wanted to add here that we do have a data documentation tool that hospitals may use internally to help them track the data for each birth, broken down by race, ethnicity, as well as birth weight for the NICU babies. It's on our website, and then I'll share it back again with all of you when I share the slides as well as the recorded video from our webinar.
Someone texted me and asked for clarification around when the slides would be posted for use in local RACs and local groups to try and support the project.
We are gonna have this uploaded by early next week on our website, and then I'm gonna share the link for everybody so that they're able to download it as well as download the slide.
Fantastic.
We see a question here about when we will receive the data entry tool. And I just want to clarify what you mean by that. Are you referring to the REDCap login where you will actually enter the data, or are you referring to a tool that will help you collect the data? The form to enter the data. Maliha, I'm going to let you answer that one.
Yes, so as next step, so in the next few weeks, you're going to receive an email from us. We're going to contact each of the individual hospitals who have fully enrolled. We're going to share your REDCap ID. We're also going to share instructions on how to access REDCap and then how to enter the data, along with your unique hospital ID. So those are going to come in the next 2 weeks.
Another question here that I'm going to direct to our project leaders. For mother baby units, can the first temperature be excluded if a second is taken and normalizes within 60 minutes?
This is Rashman Savani. I'll take that. So for the mother baby units, the temperature that is taken between 20 minutes and 60 minutes is the one that counts. When we did the project in the North Central Texas RAC, we noted that if mom had choreo, the first temperature was high, and it had normalized by the time 20 minutes was done. So the mother baby units will be the temperature taken between 20 and 60 minutes, but for the NICU, it'll be the admission temperature right on admission.
A few questions about clear instructions on when and how many temperatures will be tracking initial temp and the first admission temp.
There will be only the initial temperature in the NICU on admission, and for mother baby unit will be from the temperature between 20 minutes and 60 minutes of life. And then what you will do is you will record the number of babies that were below a certain temperature or above a certain temperature, which will allow, together with the total number of births in your facility, allow a rate of hypothermia and a rate of hyperthermia to be calculated.
Dr. Savani, it's Dr. Nedrolo. The interesting question that just came through that noted that one particular hospital is measuring well baby temperatures at both 30 minutes and 60 minutes. So the question is, which one do we choose? And I agree, we need to choose one, and it may be, go ahead.
Sorry, I didn't mean to interrupt, Jonathan.
No, this didn't come up in our, because we predefined this, and many of the hospitals were measuring it right after birth. But it seems to me that the 60-minute one might be the one to choose.
Yeah, I think we just pick one and do the same one every time. Probably the one furthest away, but within 60 minutes is probably the most accurate. You have to balance between measures taken to normalize temperature versus a true admission temperature. So I actually would favor the 30 minutes because you don't, it is after that 20-minute time frame without any measures to normalize the temperature. What do you think, Jonathan?
Yeah, we might scratch our heads on this one. It's a good one. I can see how the delivery room environment and some of the initial steps in newborn care that might lead to hyper or hypothermia, you might easily be measured at 30 minutes, and if you wait too long, then there could be new variables introduced. But in some ways, as long as it's between the 20 and 60-minute mark, if there's measurements at 60 minutes, maybe those aren't perfect every time. And if you've got a choice between 30 and 60, just from a logistics perspective, the 30-minute one might always be within that 20 to 60-minute time zone, so to speak.
I think it's important to do it consistently. So pick one, either the 30 minutes or the 60 minutes, and just report that one.
Exactly. And if they notice that the consistency within their data collection is more favors the 30-minute one and 60 minutes sometimes is 65 or 70 minutes, then I would always pick the more consistent one and go with 30.
I would agree with Dr. Sabani. I think the goal of this project in one sense is to create an idealized environment into which we introduce a baby for euthermia. And you'd hate to get one at 30, have a cold baby, warm them up under a warmer at 60, and then report a normal temperature. So it just seems that probably that first temperature obtained between 30 and between 20 and 60 minutes is the best.
Well said.
We're getting a couple of additional questions in the Q&A. I just want to read them out loud. One is asked by Susanna. She said, will someone be able to share an NPR report to be able to answer all the questions for the project? I'm in the process of creating one, but has proven a little difficult. Maybe a hospital will be willing to share the syntax for Meditech's NPR. Any comments from our speakers?
I can tell you that if it's Meditech, I know that that a large hospital in Houston is working on this. I think that we can, if Susanna, if you want to contact Maliha, we can route you to that contact and have them help you with it. Because I do know that that Meditech, there's a Meditech related report that they're working on.
Thanks, Dr. Weisoli. We have another question. It says, this is from Avis. Does this include infants in warmers?
The answer to that is yes. It is however you admit the patient to your unit or mother baby unit, as long as the temperature is taken on admission in the NICU or between 20 minutes and 60 minutes in the mother baby unit. So we're not asking you to change any process that you currently have with the way you handle babies.
There was another question in the Q&A that I typed in an answer for, but we've received it from a few people, so I wanted to bring attention to it quickly. The question was, if you have a mother-baby patient that is later admitted to the NICU, which should they fall under, or should they fall under both categories? And the answer is under both categories. This is more tracking the admission process than the patient. So if a patient is originally admitted to the newborn nursery and then transferred to the NICU, that patient has two different admissions. And so it's the admission temperature for each admission.
This will mean that some babies are double counted, but that's okay. The point of the project is the thermoregulation in the newborn, whether it's the first or the second admission.
Okay, here's a new question for NICU. Is it the temperature in the OR or temperature once baby comes into the NICU?
when the baby comes into the NICU.
Yes.
Right, it would be the same definition used for Vermont, Oxford, or other databases with that. So yeah, the first one in the NICU, not within the OR or the delivery room.
And really the temptation here too is to not intervene. You report the first temperature, not one that's post-intervention once you find a cold baby. So at the point of admission to the NICU.
But there are many, guidelines that people will take a temperature during, right after stability of resuscitation.
Sure.
To see where they are. A lot of times those are just to prevent hyperthermia in many cases, a lot as well, but that would not necessarily be the one. We're talking about when you actually admit to your resting location in the NICU.
In
had
response,
a question also. She asked, not sure if this was asked or not. We do recovery for 2 hours. The temperature you were looking at is when they go up for transition, or is it during the 2 hour?
So this is it specifically to the well babies, I assume.
Yeah, you have to clarify. You mean recovery, meaning you keep the babies with mother for 2 hours in recovery? I'm confused by the question.
And she said yes in delivery.
so that would again mean when the baby is admitted to the mother baby unit, after that recovery period is the temperature we record.
But I guess her point is it's after 2 hours that they're quote unquote admitted to the mother baby unit. Is that correct?
So
That would be an instance where we need to introduce a temperature collection point in time between 20 and 60 minutes of birth. Assuming they aren't already collecting temperature. I suspect they are, even though they're recovering the mom.
I have to admit, everyone is asking really fantastic questions, things that we actually had not thought about before. So I think that's why this is such a good idea to have a statewide call so that we can answer all these questions. I think if we're thinking about temperature and how we prevent babies from getting too hot or too cold, probably would be best to get the temperature within 20 to 60 minutes after birth, which would be that you would have to take that temperature in the recovery or delivery area.
So what Alana Garris put in there, the temp for newborns would have to be done within the 20 to 60 minutes, regardless of where they are. We are talking about well newborns in that situation. So yes, we would suggest a temperature there. 2 hours before our first temperature is probably a long time. So yeah, if we're trying to, in the interest of doing the best for euthermia, that's what we would ask for.
I think that highlights the power of what we're doing here, because there are so many different environments into which babies are born, and our goal is to really idealize all of them would be what we would want. So these are great questions.
In response to Tracy Calhoun, it is 20 to 60 minutes after birth, not 20 to 60 minutes after arriving at the mother baby unit.
Yes, we're sorry for the confusion. We may have misspoken on that, but it's 20 to 60 minutes after birth.
Okay,
Go
another
ahead.
question. In response to the above question, a data collection tool we can use to track data. The link in the answer does not return any tool. The page says we couldn't find the page you were looking for.
Sorry, so I was just gonna type that answer. We will send you after the summit, along with the presentation slides, we're gonna send you the tool. We're gonna send it to you directly.
Okay, another question, if the baby is transferred to the NICU the next day or later, are they still tracking that NICU admission temperature?
Yes.
all admissions to the NICU, irrespective of when they happen.
That's right.
This is where you'll get some double counting, but we understand that. It still fulfills the same mission to have a good temperature.
Another question, is there a mechanism to capture infants in the NICU that are being intentionally cooled for HIE?
There is. That's one of the data elements that we will understand which babies were purposefully cooled for that therapeutic reason. So we don't count them as deficient with euthermia.
So the next question from Tammy Watson is, do we exclude babies that were born at home and may not reach us in the time period for newborn nursery? I think that we should record the admission temperature when those babies come. I don't think this is going to be a huge number of babies, so it won't affect the data as much.
It's an excellent point, though, Dr. Savani. That was something that we had not anticipated per se, and that's the entire purpose of rolling this out statewide. The tightness of the data collection and the quality improvement project will only be enhanced by these additional manifold participants across the entire state. It's an excellent question.
Another question just popped up, if the baby transfers back to the mother baby unit from the NICU. And I think there might be two parts of that. If they go straight to the NICU and then back to the mom baby unit, and then also if they start in mom baby, go to the NICU and then come back. I think there's might be two answers there.
That's an interesting one.
These are really great questions. So my sense is, and I also need the help of Drs. Nedrolo, Wysoli, and Lloyd, is for the mother-baby admissions, we probably want to focus on the 20 minutes to 60 minutes. And for NICU would be for any NICU admission at time. Going back to the mother-baby unit, the baby's already been stabilized in the NICU, likely will have thermal regulation as part of that management. And my initial answer to that question is to not include a readmission to mother baby after going to the NICU. What do the others feel?
Yeah, I agree with you, Dr. Savani. It feels like those babies have been under the care of the NICU for probably some period of time. And as you say, they'll be stabilized. It is a transition of care between the NICU and the well baby unit, but I think the risk of babies becoming hypothermic during that transition or hyperthermic during that transition is relatively low. And it makes it for a cleaner project and less data collection if we just have the already proposed moments of time and places for temperature collection.
Power in this project is the size. And our goal is one of the stated goals is to keep it as simple as possible so that it would be as
Yep.
minimally burdensome to all the data collectors and the people taking care of all the patients as possible. So I would agree.
And in response
Another
to
question.
Avis Harris Caldwell, if the baby is hyperthermic, will we need to document any interventions or just the baseline temperatures according to parameters? So this is just a report of the baseline temperatures according to the parameters. Every system has their own way that they do thermal regulation, and the temperature is sort of the outcome measure, if you will. So we will just be recording the temperatures according to the parameters described.
I know a lot of questions came in through the chat, and I want to make sure we didn't miss anything. If you still have a question, if you can enter it into the Q&A box for us, it's a little easier for us to see it over there. We have about 5 minutes left. I want to make sure we're answering as many questions as possible. We will also be compiling many of these into a frequently asked questions document that we'll send out after the webinar so you all have access to the answers going forward.
Amanda, there have been a couple questions about this topic, which is ethnicity, reporting on that. So you see this question from Harold McGee. As these reports are being built or modified, will you send us a list of all categories we need to pull from our EHR? The current report I run does not have ethnicity. We will need the list to be able to get our Epic builders to change my report. So that, I think you guys can answer that one. Yes.
Yes, I sent them the link for all the race and ethnicity categories. We are gonna go back. We are gonna, like Amanda mentioned, we're gonna update our FAQ to reflect these questions, and then we're gonna send that back again. And we also request that you reach out to us at nat@utsystem.edu, and we will be, if you have any further questions, we will be getting those to you as well.
So in
If you
response,
could just email me, then I can check whether if you are completely enrolled.
in response to Kathy Montgomery for the question for NICU patients, data collection includes total number of NICU admissions and a subset of very low birth weight infants, correct? Yes, the metrics will be total NICU admissions and proportion of infants hypo or hyperthermic within the NICU population. And then you change the denominator to all very low birth weight infants and the proportion of those infants that were either hypo or hyperthermic.
I know we've only got a couple of minutes left, but this is Nedrilo again. And I think Harold brought up a good question about race and ethnicity and constructing reports. We're fully aware that that question is we're not re-asking that question. That's a question that's already been asked by the admissions process at the hospital. And that's the data that we're asking for. And so one exchange that'll happen, I think, organically during this process, during this project, will be how much variation is there in how that question is asked. We realize that race and ethnicity is a complex topic, and we do have understandable pragmatic limitations as to how it's being asked during the admissions process. So we have our way of parsing out race and ethnicity, but that may not fit perfectly into how each hospital is capturing it. And so that should open up a dialogue, and please ask questions about that, and we'll attempt to standardize that information as best we can.
I think that, as has been highlighted today, there will be things that come up that we need to work through, and our goal is to be a resource for you, to help you however we can. And I just want to emphasize what a wonderful job everybody's done to get us to this point. We've got 220 people still on. We had 260 people on, so great job. And thank you so much.
And I'd also like to remind people that enrollment is ongoing. So in the case that you are not able to get this obviously done in time for next week to be able to start collecting data, we're continuing with enrollment. So understand that we can shift your cycle. We obviously want to get everyone as early as we can, but it doesn't mean that if you haven't done this by April 1st, you cannot enroll. I absolutely want to emphasize that, yes, you can. I know Maliha already mentioned that earlier, but yes, please, we want to help. And enrollment is one of the biggest things. The three components of enrollment: the enrollment form, the needs assessment, and the data use agreement. And we're happy to help you with any and all of them as much as we possibly can. That email, nat@tchmb.edu, is a great way to ask for any help, but any of us at any time as well.
tchmb.org.
We have our email addresses both for the NET project as well as the general Tchmb on here. So again, we wanted to thank, I know we are right on time. We wanted to thank all of you for attending, and these are very great questions. And again, we are going to follow up with you. If there were questions that we did not get answered to, please email us at net@utsystem.edu and we will get to those questions. But we are going to follow up with the webinar materials as well as an updated FAQ. And just to remind everyone again, you're also going to hear from us with your unique Red Cap account information and your unique hospital ID, so that you can start submitting data to us, which is not going to be until July. But again, thank you all for participating. Thank you all for attending. We know how busy all of you are and how we want to be respectful of your time. And if you have any questions, please feel free to reach out to us. Anything else the team wants to add?
Thank you, everyone.
Wonderful job.
Thank you.
Thank you so much.
Job.
Have a great day. Be safe.
Bye-bye. Thanks.
Bye.
Thank you. Bye.